स्टार्ट कर दूंगी। ये अप डाउन ये है ना? Hi, good morning everyone. Today we're going to discuss one of the important public health problems, especially in developing as well as developed country. It's called acute bacterial meningitis. If you remember the last discussion that we had, we talked about enteric fever, and I told you that that is a disease specifically for developing country because that is enteric fever is transmitted through fecal-oral route. Therefore, drinking water is the vehicle of transmission. But the organism, the bacterial organism causing acute bacterial meningitis affects both the developed as well as developing world because this bacterial group of bacteria that causes meningitis can be transmitted through aerosol or droplet nuclei. So that is the difference because acute bacterial meningitis is also a major problem in developing country as well as developed country. That's what we're going to discuss. What do we expect you to understand at the end of this discussion? You must understand the commonest etiological agent of acute bacterial meningitis. You have to understand that a large number of different bacteria, pathogenic bacteria, can cause a varieties of disease, but we are enlisting the most common bacteria worldwide that are associated with acute bacterial meningitis. So you must remember those 5 or 6 common bacteria that cause acute bacterial meningitis across the different age group. We must understand the epidemiology. I gave an example of the enteric fever, saying that enteric fever is a fecal-oral route, therefore the transmission is through contaminated water, so a safe drinking water will definitely prevent it. Since it's not available in developing country easily, it's a disease of the developing country. But this particular disease, acute bacterial meningitis, is transmitted through aerosol as well as a droplet nuclei, just like the coronavirus. This will affect any population in the world. Then we will discuss about the pathogenesis. We will touch upon the little bit about the physiology of the blood-brain barrier, because you have to understand that this disease process compromises the blood-brain barrier or neurovascular unit, and then it can cause havoc inside the brain. Then of course the topic will also include laboratory diagnosis of acute bacterial meningitis. What are the different modalities? How you can immediately bedside as well as in the laboratory you can do different kind of testing for samples for acute bacterial meningitis, and then isolate the organism and do antimicrobial susceptibility pattern on the organism. With this understanding, let's look at the definition of acute bacterial meningitis. Bacterial meningitis is an acute purulent infection within the subarachnoid space of the central nervous system. Although it starts with the subarachnoid space, but the inflammation will slowly spread all over the globe, the brain, and subsequently include the brain matter as well as the other meninges. So you have to be very clear about it. Looking quickly at the epidemiology, there are more than 1.2 million cases annually that is seen in the worldwide, and approximately 150,000 deaths. This is mostly in developing country because developing countries do not have an access to immunization against the disease. And plus, in the developing country, there are overcrowding, there are in the slums, so there are many people living in a small area where the disease can be transmitted through aerosol or droplet nuclei very easily. We also have to understand that bacterial meningitis is one of the top infectious disease cause for death in the worldwide. You will also have to understand about 30 to 40% of these individuals who suffer from acute bacterial meningitis will invariably land up with certain neurological damages, whether it can be facial palsy or weakness in the limb or slurring of the voice, etc., etc. So we have to understand that a significant proportion of these individuals who recover from acute bacterial meningitis will have some side effect, neurological damage if the individual is not diagnosed immediately and treated properly. Very quickly, let's look at the anatomy of an intracranial space. You already know that from inside to the outside, if you look at from the inside to the outside from the brain, you have the pyometer covering the cortex of the brain or brain parenchyma. Then you have this particular steps, and then you have the arachnoid matter. Between the arachnoid matter and the pyometer is the subarachnoid space, and above the subarachnoid space you have the dura space, and the in between the dura you may have the different kind of sinuses. You have to understand that this subarachnoid space is a loose space, trabeculated, and there are many many different blood vessels in this area, and this area subarachnoid space is usually occupied by the cerebrospinal fluid, and this space is continuous with the rest of the spinal cord, just as you can see the dura mater, the subdural space, the arachnoid matter, and you have the pyometer, and just below the arachnoid matter you have the subarachnoid space. So this space is actually covered by the cerebrospinal fluid. just just emphasizing the fact that the brain parenchyma, the pyometer, then you have this subarachnoid space which is filled up with the cerebrospinal fluid. So what is the subarachnoid space? Subarachnoid space is a fluid filled closed space which is deficient in immune defense mechanism. So we are going to talk a little bit about the what is the immune mechanism that exists inside the brain. If you look at the periphery of the blood or periphery of the body, you have the uh, uh, vascular system where you have all kinds of different innate immune response, different components. You have the adaptive immune response component, both the humoral as well as the cellular component. But inside the brain, in the subarachnoid space, there are hardly there are very few components of the immune system playing in the role. There are very few complements in the complement component in this subarachnoid space. Therefore, absence of the complement helps the bacteria multiply if the bacteria gets inside the subarachnoid space. There are few WBCs. Normally, in the peripheral blood, you have 5,000 to say 11,000 WBC per cubic millimeter. But in CSF sample, you have 0 to 5 or 0 to 10 white blood cells per cubic millimeter. So there are the number of WBCs, number of complement component, and number of immunoglobulin molecules are significantly lower. If you look at the, if you compare the peripheral immune system with the central nervous system, you will realize that it is almost the immune system inside the brain is very uh, compromised in the sense that if you look at from the scale of 10, if the peripheral immune system is, if you can score it as a 10, then the immune system inside the CNS will be probably 2 or 3. Why is it? It's because if you have a large number of immune cells inside the brain, any kind of inflammatory process that involves these immune cells or immune component, it will destroy the neural tissue. And you know that neural tissues are non-terminal and non-regenerating cells. So you don't want a large number of different immune system component inside the CNS that can eat up the brain. But at the same time, you will require a certain amount of immunoglobulin, certain number of WBCs, certain amount of complement to keep a check on the monitor the inside the brain, so that it can warn the rest of the immune system that there is a problem inside. So this is what we're going to discuss in a little while. One of the important component in the CNS is the cerebrospinal fluid. I already told you that cerebrospinal fluid circulates in the subarachnoid space, but it actually originates in the both the lateral ventricles as well as third ventricle as well as the fourth ventricle. So inside the ventricle you have this choroid plexus, and in the choroid plexus you have the ependymal cells, and these are the ependymal cells which are responsible for 80% of the production of the CSF. Rest of the 20% of the CSF is actually produced by the brain parenchyma. So brain parenchyma will form a large amount of about 20% of the CSF, and this will come into circulation through interstitial fluid passage that we are going to discuss in a little while. So what is the amount of why is CSF important? CSF normally function as a cushioning effect for the brain, so that if you move your head from one side to another, it will give you some kind of cushion. Plus it will also carry large amount of metabolic products of the brain from the CSF, and it will drain finally into the central venous system, and this will also carry the different metabolic product finally into the venous system. So what is the total volume of CS at one point of time? The total volume of CSF that is present inside the brain is about 100 to 150 ml. This is the amount of CSF that this is a very highly dynamic status. So the fluid will during inspiration your fluid circulation might CSF circulation might increase. During expiration it might go down. What is the amount of CSF per minute that is produced? It's 0 to 3 to 0.3 to 0.4 ml per minute CSF is produced by this ependymal cell of the choroid plexus as well as the parenchyma. We have to also understand what is the pressure inside the subarachnoid space. The pressure within the subarachnoid space is CSF space, because that is continuous with the lumbar and lumbar spinal cord. The pressure is 80 to 180 millimeter of water. You must remember 80 to 100 millimeter of water. If the pressure, if you are going to do a lumbar puncture, if the pressure is extremely high, then the fluid will eject immediately with a very high force, and it will end up 2-3 feet away from the individual. And you already know that if there is a very high pressure inside the brain, because the CSF is blocked and CSF flow is blocked, it might push the brain down through the medulla oblongata and may cause death. So knowing the pressure of the CSF is very, very important. There was a hypothesis saying that CNS, central nervous system, the core system of the neural component, where all the activities, all the neural information are transmitted or produced, is it an immune privileged site? That means, is it devoid of any kind of immune component? That's what we're going to discuss a little while. But if you have to understand that the brain is encased within the skull and connective tissue from outside, and from the inside it is separated from the vascular component by the blood-brain barrier. So these are the two important components that separates the CNS or central nervous system from the environment. One is that skull and connective tissue physically making the barrier, and from the inside, from the brain parenchyma, the blood-brain barrier itself will separate any kind of fluid from going from the vascular component directly into the brain parenchyma. At one point of time, it was thought that brain is a closed space, immunologically inert. So there is no immunological activity. This is absolutely now there has been absolutely change in this idea that brain is not an immunologically inert area, because if you realize that inside the brain you have you have certain number of B cells, certain number of T cells, certain number of macrophages, microglial cells, etc., which are necessary for the homeostasis of the CNS or central nervous system and neural tissue inside the brain. The whole idea was that immunologically, why is it should be immunologically inert? That you expect that if any kind of inflammation that is seen in the periphery, if similar kind of inflammation is produced inside the brain, the non-regenerating post-mitotic neuronal cell will be completely damaged. So it was that CNS immune response is not essential, as systemic immune response makes them redundant, because as I told you, peripheral immune response is a robust immune response. It has all kinds of innate immune response. You have adaptive immune response, both humoral as well as the cell mediated immune response, in addition to the natural killer cell and so on and so forth. So it was thought that because you have such a robust immune response in the periphery, this manner, so the whole idea of the brain being immunological inert is not correct anymore. So there are changes in the idea. There is a paradigm shift in the, so the paradigm shift is that immune response in the CNS is important for the growth, repair, optimum function of the neurons. So the neurons, for the healthy homeostasis of the brain or healthy activity of the neural tissue, there are certain amount of immune response component, like the natural antibodies or presence of the B cell, or presence of the T cells are important. Immune response plays protective role for neuron in steady state condition. As I told you, certain amount of antibodies that are present inside the brain helps to maintain the neurons in a steady state condition. This is the new idea, and this says that although the immune response inside the brain is rudimentary if you compare it with the peripheral system, but it is present. It is not only present for the infective surveillance of the infection or controlling the infection, but it is also important for to maintain the normal homeostasis of the brain tissue. Without the immune system, immune component inside the brain, the neuronal tissue cannot function normally. So let's quickly look at what are the different components that play a role inside. What are the different immune component that is present inside the brain? First, you have to understand that the most important component that regulates the protection inside the brain is the blood-brain barrier, or also it is called neurovascular unit. This is the most important. Why do you need to know about the blood-brain barrier? Because this blood-brain barrier, as we will talk in a little while, this controls the passage of fluid, solutes, glucose, etc., from the vascular component into the brain parenchyma. It is very important because during inflammation, during trauma, this may be compromised, and it can cause severe or serious impact on the parenchymal cell. Second component of the innate immune component of the CNS is the microglial cells. Now, microglial cells are actually, although it is present inside the CNS, inside the parenchyma on the surface of the brain, the microglial or the origin of the microglial cell is mesodermal origin. That means these cells are actually present in the mesoderm. It migrated from the mesoderm, yolk sac mesoderm, and subsequently went to the CNS. And the number of microglial cells, density of the microglial cell is extremely high inside the brain. Up to 8,000 cells, microglial cell can be present in a per cubic millimeter of the brain tissue. So the function of this microglial cell, that It acts as a resident immune cell inside the body, and it also monitors the surface of the brain for any kind of changes in the brain parenchyma, be it a microbes, be it a tumor, or be it any kind of amyloidosis or etc. Parkinsonism changes or amyloid changes inside the brain. In addition to the blood-brain barrier, microglial cells, you have astrocytes. Astrocytes are glial cells. That means that these are non-neural cells, but they originate or they actually originate from the neural crest or the ectoderm. The function of the astrocyte is that this astrocyte is associated with the neural tissue, and it carries a large amount of different aquaporins. What are the aquaporins? Aquaporins are channels that are present in the astrocyte that helps the neuronal maintenance of the neuronal tissue. In addition to this, there are pericytes which covers the blood vessel inside the brain. If you compare to the CNS immune component to the peripheral component, you already know that peripheral component is composed of the innate as well as the adaptive immune response, and these are the T cell, B cell, mast cell, monocyte, etc., along with the humoral response as well as the adaptive immune response. What is the role of the immune cells in the CNS? I already told you that inside these immune cells, specifically microglial cells, there are different kinds of microglial cells, type 1, M1 or M2. These microglial cells are actually like spider. So what they will do, they will spread their tentacles over the surface of the brain and look for any kind of changes, be it a microbial infection or be it a tumor or be it a injury to the brain, etc. So if there is if the microglial cells recognize any kind of, say, antigen, either tumor antigen or microbial antigen, then it will produce a large amount of different cytokines. It will grab up the particular antigen and present it to the circulating T and B cell that is inside the brain. Okay. So let's quickly look at what is the blood-brain barrier and why is it important to understand. Blood-brain barrier is also called the neurovascular unit. It's a structural and functional barrier between the blood and the CSF. You know, the blood is your vascular system carries a large number of different components which may be healthy for the individual, which may be unhealthy for individual, but it may carry a large number of different kind of metabolic products. These metabolic products have to be prevented to reach the brain parenchyma. As I told you that brain parenchyma, the neuronal tissues are non-regenerating and terminal, very specialized cells. If these unwanted products from the blood enter the parenchyma, it may cause severe damage. So it will fulfill the blood-brain barrier mainly fulfills two functions. That is, acts as a physical barrier. Secondly, it acts as selective exchange barrier. What kind of selective exchange barrier? Let's look at the first. Let's look at the. We talk about the transportation of water and solute across the blood-brain a little later. But first, look at what is the composition of a neurovascular unit or blood-brain barrier. So, if you look from inside to outside, first is the vascular endothelium, tight junction adhesive molecule. So, from the blood vessel to the outside to the brain parenchyma, first the vascular endothelium, then you have the capillary basement membrane, then you have the microglial cells surrounding blood vessels and pericyte and perivascular astrocyte. So this will be clear from this picture. So we have this endothelial cells, and then you have the basement membrane of the endothelial cells. Then you have this astrocyte, the pedestal, foot end of the astrocyte, and the microglial cells also will be touching this, and some of the neuronal tissue will also touching this. These astrocytes and the basement membrane, the endovascular neurovascular unit has the ability to express a large number of different molecules on the surface, as well as both the basolateral and the luminal side. It can express a large number of different transporter molecules like aquaporin, etc. Sugar, glucose transporter molecule, sodium, potassium chloride transporter molecules. So the transmission of fluid across this blood barrier can be both active as well as the passive, and this transfusion of fluid from inside to the brain is extremely highly regulated, and this regulation of the fluid transport from the inside the vascular component into the parenchyma may be affected during different conditions. So this is another picture just to show you. This is the neurovascular unit, endothelial cell, basement membrane. You have the astrocyte, the foot end of the astrocyte. It expresses a large number of aquaporin. The pericyte that covers the blood vessels, microglial cells, and astrocyte, and these are the neuronal cells. So this whole unit acts as a some kind of a, if you know about the earthquake seismic sensors. Seismic sensors are the sensor that detects, that are dug inside into the ground and deep into the ground, at it senses vibration if there is a earthquake prone area. So it can warn you about the. Similarly, all the cells of the neurovascular component can detect any changes inside the vascular component, presence of any kind of unwanted microbial life inside this epithelial cell, endothelial, inside the endothelial in the compartment. And if these microbes, like say for E. coli K1 antigen, or say meningococcal meningitis bacteria inside. So this will cause disturbance, and this will cause the endothelial cells to secrete inflammatory response, and this will be detected by pericyte, this will be detected by the astrocyte, this will be detected microglial cell. So all this microglial cell, astrocytes, etc., that are surrounding that surrounds uh, the blood vessels will automatically synthesize a large number of different cytokine, and this cytokine will subsequently produce uh, will cause disturbance in the blood brain barrier, and then the fluid as well as leukocytes, etc., WBC will start leaking into the brain parenchyma, and it can cause havoc inside and it can cause inflammation inside the brain parenchyma. A few years back, a rudimentary lymphatic system was discovered inside the CNS. What is this rudimentary lymphoid tissue, lymphatics of the CNS? Once you realize that brain parenchyma produce a large number of different metabolic products as well as fluid. These are called interstitial fluid. So this interstitial fluid is transmitted from the brain parenchyma into the Virchow or Virchow-Robin space, and from this space it gets into the space between the blood vessel and the pile sheath. So the gap between the blood vessel and pile sheath is the gap where the interstitial fluid is transmitted outside. So this space is called the lymphatics or glymphatics of the CNS. Finally, the interstitial fluid from the brain is carried through this space between the yellow line and the red line is the blood vessel. This is the pile sheath. So the glymphatic space or glymphatic channel is present between the pia vessel, the vessel pile sheath surrounding blood vessel, and the blood vessel wall. So this space, and it will finally drain into the sigmoidal sinus or different dual sinus. As I told you that it is important to understand because the blood-brain barrier is controlling or regulating the transfusion of different component and transportation of different component from the vascular component to parenchyma solutes as well as sodium, potassium, electrolytes as well as water. During infection, hypertension, hyperosmolarity, microwave, radiation, etc., this blood-brain barrier can be damaged. And if it is damaged, then you already understand that this will cause severe impact on the neuronal tissue. So what are the different components there? You have the reactive oxygen superoxide molecules, different metalloproteases, angiogenic factors, inflammatory cytokine. So all these component pathogen can damage the blood-brain barrier. What will happen if the blood-brain barrier is damaged? It will increase the permeability, reduce the endothelial TJ junction leakage. It will cause impaired transporter function, insufficient clearance function, pericyte detachment, astrocyte loss, so and so, disrupted basement membrane. And what will going to happen if the blood-brain barrier is gone? Imbalance of ion transmitters, leakage of plasma protein, entry of toxin pathogen directly into the and production of huge amount of cytokine inside the brain component, and it will lead to neuronal dysfunction, neuroinflammation, neurodegeneration. This is what I was telling, that a significant proportion, up to 40 to 50% of the individual who suffer from acute bacterial meningitis, if not diagnosed early and not treated properly, may end up with severe neurological damages. You know, once the bacteria or any microbe is encountered in the peripheral blood, antigen presenting cell or like macrophages, then dendritic cell, etc., will capture the microbe and break it down and present in the T helper cell, etc. And the T helper cell as well as the T cytotoxic cell will produce subsequent inflammatory response. But as I told you, but this in the CNS, if the microbe is somehow lands up with the neurovascular endothelium, this may cause damage. This may cause damage to the endothelial cells, and presence of the microbe inside the endothelial cells will cause leakage in the, as I told you, it will cause in the leakage or breakage inside the endothelial. So it will allow the microbe to get inside the parenchymal tissue, and this will lead to, and this will irritate the microglial cell or stimulate the microglial cell astrocyte to produce a large number of cytokine, different cytokine, inflammatory cytokine, interleukin 1, interleukin 6, interleukin 8, interleukin 17, etc. inside the parenchyma. So all these cells, microglial cell, astrocytes, etc., and the cells that leak through the endovascular component can produce huge amount of cytokine, and this cytokine will increase movement of the different peripheral immune cell into the brain, and this will cause severe damage to the brain. So what we have, so once the organism colonizes the throat or it is inhaled, the organism multiplies inside the brain, then subsequently some of them may die and produce a large amount of endotoxin, etc. And this endotoxin produces inflammatory cytokines, and this inflammatory cytokine altered blood-brain barrier permeability. Some of them may adhere to capillary endothelial cells, alteration of cerebral blood flow, production of excitatory amino acids, reactive oxygen, etc. Finally, what will happen is this will cause leakage of a large amount of fluid from the vascular component into the increased permeability of blood vessel, leakage of plasma protein into the CSF. And this will cause exudate presence of large exudative fluid inside the cyberarachnoid space, and this will obstruct the outflow of the CSF that I already talked about. CSF circulation will be obliterated, and this will cause severe pressure on the brain, and some of these areas in the brain can be affected through cerebral ischemia because of the reduction of the blood flow, etc., or it can be directly affected the cytotoxic cytokines that is present. It can be because of the cytotoxic edema. So finally, this will lead to increased intracranial pressure because the CSF outflow is compromised, and this will subsequently lead to coma. That was the part of the physiology of the how the brain neurovascular component works inside the brain and different immune cells that affects the CNS. Let's quickly look at what are the different etiological agents that actually cause bacterial meningitis. I told you that there are large number of pathogenic bacteria that can cause different disease, including acute bacterial meningitis. But we have to understand there are 6 or 7 bacteria which are worldwide known to cause if it has specific predilection or specific affinity for neural tissue. What are these organisms? Streptococcus pneumoniae that cause pneumonia, and Neisseria meningitis is caused meningococcal meningitis as well as meningococcal. Listeria monocytogenes, that's another gram-negative bacteria. Haemophilus influenzae that affects mostly in the children, or group B streptococci that is mostly found in the pregnant women in the birth canal. So these are common organisms that are associated with acute bacterial meningitis. Streptococcus pneumoniae, the most common, Neisseria meningitis, Haemophilus influenzae, Staphylococcus aureus can cause, Mycobacterium tuberculosis cause chronic infection. In addition to this, there are a few other organisms like Escherichia coli, group B streptococci, Listeria monocytogenes. These cause neonatal meningitis. Why this cause neonatal meningitis? Because all these 3 organisms are present in the birth canal of the pregnant women. So in certain in developed country like US, the CDC guidelines, Center for Disease Control guidelines says that any pregnant woman should be screened at 34 weeks for group B streptococci and Escherichia coli and Listeria monocytogenes. And this screening for this organism has reduced the neonatal meningitis in the US to a large extent. So we talked about this common organism causing acute bacterial meningitis, Streptococcus pneumoniae, Neisseria meningitis, Haemophilus influenzae, Staph aureus, Mycobacterium tuberculosis that causes chronic infection. This is not a cause of acute bacterial meningitis. These 4 are acute bacterial meningitis. This I have included in this just to complete this story. In addition to this, acute bacterial neonatal meningitis are caused by these 3 organisms: Escherichia coli, K1 with K1 capsule, group B streptococci, Listeria monocytogenes. These 3 are, as I already told you, these are present in the birth canal of the pregnant women. So during delivery, these are acquired by the baby. So what are the, just quickly, what are the predisposing factors for neonatal meningitis? Prematurity, prolonged rupture of the membrane, low birth weight, and maternal perinatal. All these predisposing factors help these organisms that are present in the E. coli, group B streptococci, Listeria monocytogenes from the birth canal to go upward and affect the child affect the baby and the fetus inside the uterus. So little bit about the neonatal meningitis. There are 2 kinds of neonatal meningitis. One is early onset within 7 days. This is where the organism comes from the birth canal. Late onset within 28 days or 3 to 4 weeks. So this comes from the late onset neonatal meningitis comes from mostly from the caregivers other than the mother. So between these 2, the early onset is from the birth canal, the late onset from the later onset neonatal meningitis can be any organism, and this is mostly come from the health caregiver other than the mother present in the household. Now to skip this. One by one, let's quickly look at the etiological agent. Haemophilus influenzae, you already know. This is a gram-negative bacteria. It carries there are different serotypes, out of which serotype B or Haemophilus influenzae type B was the most important, is the most important because it carries certain kind of capsular polysaccharide which is called polydiabetyl ribose phosphate. So type B is the most important and most notorious for producing acute bacterial meningitis. But now we have an extremely good vaccine against type B meningitis. Therefore, Haemophilus influenzae type B meningitis has been almost eradicated from developing country. Fortunately for India, type B meningitis vaccine, HIV vaccine, conjugate vaccine is available, and although it is not a part of the uh, extended immunization program, that this vaccine is available now. And this is how the organism gives a sand-grain appearance in the CSF. So if you see very small sand-grain appearance gram-negative bacteria in the gram stain, you will know that this is Haemophilus influenzae. Of course, you need the other biochemicals, etc., to identify the organism. So this organism has a extensive virulent capsular polysaccharide called polydiabetyl ribose phosphate. As I told you that Haemophilus influenzae type B is a major cause of meningitis worldwide, mostly as I told you because there are in the developing country there the healthcare facility cannot afford to give appropriate conjugate vaccine, so the cases are still very high in the African continent and certain part of the Southeast Asia. Fortunately for India, we are administering HIV vaccine to the children. So if you just to emphasize the fact that how a vaccine actually can prevent the meningitis. So this is before the pre-vaccination era and this is post-vaccination era. So once you give the HIV conjugate vaccine, Haemophilus influenzae conjugate vaccine. What is a conjugate vaccine? Conjugate vaccine is a vaccine that has capsular polysaccharide attached to a protein molecule. This protein molecule can be tetanus toxoid, or this protein molecule can be diphtheria toxin, etc. So this conjugation of the capsular polysaccharide with the protein molecule makes that is the conjugate vaccine, makes the immune cells initiate T help activity, T helper cell activity, and because of the T cell helper activity, this induces memory. So this vaccine is it can be given in children below 18 months of age, and it is extremely effective. As you can see, in the US, before the pre-vaccination area, Haemophilus influenzae caused more than 90% of the meningitis, and post-vaccination area, there's hardly any Haemophilus influenzae type A vaccine. So is the case in UK and Chile, that's South America. So we have a very extensively successful efficacy as Haemophilus influenzae type A vaccine. Similar, Streptococcus pneumoniae is a gram-positive bacteria, more than 90 different serotypes. It is polysaccharide capsule. It has a different kind of enzyme, neuraminidase, etc., neolysin, etc. So these are the proteases, etc. So these are the virulence factor for Streptococcus pneumoniae. There is an excellent, so Streptococcus pneumoniae is a major health issue all over the world. You can see India has more than 3,000 per 100,000 population cases. So it's a huge number. So Streptococcus pneumoniae is a major issue in Indian subcontinent. But fortunately, we have a very, these are the different serotypes. I told you there are more than 90 different capsular serotypes. But out of those 19 serotype, capsular serotype, serotype 14, serotype 19F, 5, 6A, 6B, etc. are the ones that are associated with majority of the invasive pneumococcal disease. That invasive pneumococcal disease meaning it can cause pneumonia, it can cause meningitis, etc. And against these 14 different kind of serotypes, you have excellent capsular vaccine for older individual, or conjugate vaccine for 9-valent or 13-valent conjugate vaccine for younger individual. Third important organism, meningococcal meningitis. The meningococcal Neisseria meningitis is a gram-negative diplococci, you can see, and aerobic, catalase positive, etc., etc. So this organism, you have to understand that humans are the only natural carrier of Neisseria meningitis. So during interepidemic period, the organism stays in the throat of some individual, and whenever this individual carrying the Neisseria meningitis has some cough or something, then he coughs it out and gives it to another individual. So respiratory droplet transmits the bacteria among people living in a close contact. So Neisseria meningitis is basically, because it's transmitted through aerosol and air droplets, it is a major issue in the military camps, in the schools, in the dormitories, in the jail, etc., both in developing country as well as developed country. So out of this Neisseria meningitis, group A, group B, group C, as well as W13529E. So these are capsulated serogroups which are responsible for most of the diseases in the world. If you look at the world, India has subgroup A infection, subgroup A, right from 1935, 1965, 1985, in 2005, all the outbreaks of Neisseria meningitis has been only through subgroup A. Subgroup B and subgroup C are not commonly seen in India. These are mostly found in the most B and C are most found in the North America and part of the China. Okay. Just to highlight that in India, and meningococcal meningitis has been seen for many years. First outbreak was reported earliest was 1935 during the independence movement, subsequently 1965, and recently in 1985, and subsequently in 2004 and 5. So all this outbreak in although happen in mostly in North India, these are all subgroup A. If you just want to compare another meningitis well, that is in the sub-Saharan countries. In the sub-Saharan countries, during the month of November to March, a dry, dusty wind carrying the dust from the sub-Saharan Sahara is generated, just like the loo in northern India. So this hot air that is carried from the sub-Saharan, it induces this individual living in this area to cough, and when they cough, they produce large amount of air droplet nuclei, and then that's how the disease spreads in the sub-Saharan countries. In the sub-Saharan Africa, the number of cases during the outbreaks can be as high as 8,000 cases per 100,000 population. But in India, if you look at during outbreaks, the number of cases that is seen during the outbreak can be as high as 20 to 25 to 30 per 100,000 population, whereas in the meningitis well it can be as high as 8,000 per 100,000 population in Nigeria, Cote d'Ivoire, Mauritania, Sudan, etc. So this is one of the notorious spells, but fortunately, just to inform you that Serum Institute from Pune has produced a very effective vaccine against subgroup A. I think it called Meningovac, and this particular subgroup A vaccine has absolutely wiped out subgroup A meningitis from the sub-Saharan countries. Now this particular area is infected only by W135. Meningococcal meningitis two forms. One is that it causes meningitis, The other one it causes disseminatory intravascular. It's called meningococcemia. So mostly it will cause meningococcemia will cause severe hematological bleeding or spots on all over the body. And if you take a swab from the bleeding spot, you will be able to, and do a gram stain, you will be able to see the gram negative diplococci. Staph aureus can cause meningitis. It can from the throat. It can be carried by the macrophage, go to the brain, and if it has the ability, virulent organism can cause meningitis. Okay. Physical sign and symptoms of meningitis: severe headache, neck and back stiffness, especially neck stiffness, nausea, vomiting, photophobia, and Brudzinski sign and Karnick signs are positive. So you have severe headache, stiff neck, dislike for bright light, phobia, fever and vomiting, drowsiness. So all these signs and symptoms during pandemic or during outbreak should warn an individual. This individual probably may be suffering from acute bacterial meningitis. Karnick sign, this is Brudzinski sign. I'm going to just coming to the diagnosis quickly. In diagnosis, we have to do a lumbar puncture just to treat the CSF. So lumbar puncture is the most important, along with of course radiology, CT and blood culture. So you need to put the needle between L3 and 4 or L5 or L4 F5, either between the third and fourth, or between fourth and fifth lumbar space. As I told you that pressure within the CSF in the subarachnoid space is 80 to 180 millimeter of water. If the fluid, there is meningitis, the pressure will increase. So what we need to do is with the fluid, we need to look at the CSF cell count, glucose level and CSF protein level. So one tube we do protein and glucose, second tube gram stain culture, third cell and differentials, fourth we do a PCR on that stage. Opening pressure, appearance, cell count, glucose. I told you that in the normal CSF, WBC is 0 to 5 or 0 to 10, roughly about 0 to 5. So if any increase in the WBC white blood cell in this area, that should put a warning signal. And the glucose, because the bacteria will utilize glucose in the subarachnoid space, the level of the glucose will go down. Protein, because protein will increase because blood-brain barrier has been broken, so a lot of protein fluid proteins have leaked out from the vascular component in the parenchyma, so the protein component will be high. So opening pressure, I told you normally is say 80 to 100 millimeter water. It increases more than 200. The fluid is cloudy. In WBC is very high. Serum glucose, the CSF glucose level is less than 40, and protein is elevated. So in normal CSF, pressure is 90 to 180, WBC is 0 to 8 lymphocyte, protein is between 15 to 45. In acute bacterial meningitis, because of the leakage from the blood-brain barrier, the protein level will be very high. Because the glucose is utilized by the bacteria, it will be low, so it is less than 40. So this is the normal CSF. You should be able to read a newspaper line through this. But if it is extremely cloudy because of the presence of the WBC, you know this individual has some problem there. And what about the gram stain? You do a gram stain, look for the suggestive organism, and you can take the sample. You can do a latex agglutination for all the Streptococcus pneumoniae, group B Streptococcus, etc., etc. You can also do the PCR for detection of the DNA. Treatment, depending on the organism, strep pneumoniae, Neisseria meningitis, they are an excellent antibiotic. Fortunately for us, none of the Neisseria meningitis or very few strep pneumoniae are resistant to penicillin or ceftriaxone. So most of the antibiotic will work excellent on any of these. So as I've already told you, we have an excellent vaccine for Streptococcus, both conjugate as well as the capsular polysaccharide vaccine. HIV conjugate vaccine, we have excellent vaccine. Neisseria meningitis, we have an excellent vaccine, quadrivalent vaccine against that subgroup A, subgroup C, subgroup Y, and W. There is a conjugate. There is also a conjugate vaccine for group A, group C, group A, etc. So, for majority of these meningitis, acute bacterial meningitis causing vaccine, you have an excellent available vaccine with very high protective efficacy. Just for the further reading, if anybody is interested, we had recently published several articles. One is on CNS, not an immunoprivileged site anymore, but a virtual secondary. This is published in the International Review of Immunology in 2018. This is from my lab, Dr. Nimanegi and myself. Then subsequently, we also had another publication on the International Review of Immunology, decoding intrathecal immunoglobulin, because at one point of time, nobody knew what is the source of the antibody inside the brain. So that led us to write this article, decoding intrathecal immunoglobulins and B cells in the CNS, their synthesis, function, etc. So if anybody is interested, these are available online. And there is a book published from the department under the headship of Dr. Rama Chaudhary, Meningococcal Meningitis, Recent Perspective, and it will give you a lot of information about meningococcal meningitis in North area, study of epidemic disease, etc. This actually meningococcal meningitis book covers almost all aspects of the meningococcal meningitis in India. Thank you so much. I कहाँ मैडम कहाँ है?
हाँ एक मिनट है पहले साउंड ऑफ करता हूँ मैम
मैं पेन ड्राइव दे दिया आपने? दे दिया।
नहीं दिया सर एक मिनट दे रहा हूँ सर
सर अटेंडेंस
लेक्चर किसका है?
सर ईमेल मैम का होगा
अभी
हाँ जी
सी है
अभी तो नहीं सर शील भी कमिंग है हाँ जी सर
बता देना मेरे को ना
हाँ अब नीचे चलिए
देखूंगा
हाँ ऊपर ऊपर चलिए
कितने टैबलेट
ये लो आप लो
सर नंबर तो नहीं आ रहा
46 खाली 46 हाँ
नहीं बीच में तो मिस हुआ क्या नहीं मिस हो गया
ये लो सर आप बस लो
हाँ
हाँ सर
सर का पेन
इसमें करना है सर का पेन ड्राइव चेक करो मैम
बंद तो नहीं हुई है
नहीं ठीक हो गया
सर आप मैं अटेंडेंस लगा के आपसे साइन करवा लूँ या पहले ही आप साइन
सर साइन कर
ठीक
अटेंडेंस
मैं पहले कर दूँ ये लो सर यहाँ पे 18 सर
ये डेट कहाँ डाला?
ये
साइन कहाँ पे?
नीचे से आप इतना है सबने सुना है
क्या?
ये गेम का सुबह तो 79 हुए थे अभी अभी छोड़ के चले गए
अच्छा 79 थे।
हाँ, उसके बाद अभी 46 भी बैठे थे।
तो ईमानी ले सकते हैं।
थैंक यू सर।
एक लेक्चर हो गया कोई क्लास इसके बाद बहुत दिनों से लगे
हाँ ईमा मैम आ जाएगी। इसी पे ही चलेगा। ओहो फिर तो फोटो लेने की जरूरत भी नहीं थी। हाँ ये है। ठीक है। आपका ये कंप्यूटर में कुछ है क्या? मेरा तो सर हुआ
नहीं तो मेरा एंटीवायरस डाला हुआ है। हाँ हाँ, मैं ऐसा नहीं करता। डॉक्टर देखना इसमें कौन सा क्रोनिक मेनिंजाइटिस 1 ये लो डॉक्टर आपका पेन है और सैनिटाइज कर आप सैनिटाइज करना। हाँ यहाँ पे बैठेंगे यहाँ बैठेंगे। ठीक है मैं ओपन कर रहा हूँ।
एक्स्ट्रा बोल सकते हैं क्या?
क्या? हाँ हाँ कुछ भी आप वो भी बोल सकते हैं, वो बातचीत भी कर सकते हैं। हाँ
पर मुझे लगता है थोड़ा बोलना
ये लो मैंने आपके लिए बोलने वाला बना दिया, आप डिस्कस कर सकते हैं। ठीक है मैंने डिस्कस वाला बना दिया आपके लिए। ये लो उधर से आ जाओ। ठीक है
कहाँ डिस्कस मतलब डायरेक्ट
अब आप बोल सकते हैं नेक्स्ट करके देखना सर इससे कीबोर्ड से कर सकते हो।
अच्छा कीबोर्ड से
नीचे वाला
अच्छा हाँ
नीचे ना
हाँ नीचे कर रही हूँ
एक मिनट
करना हो रहा।
ठीक है ये नेक्स्ट ये
हाँ
ठीक है
ठीक है शुरू कर दो ना। हेलो गुड मॉर्निंग। So morning हो गया था class में? Morning you had the acute meningitis session, so now we can have chronic meningitis. So chronic meningitis, when we say chronic meningitis, when the sign symptoms it persists for more than 4 weeks, then we say that this is a chronic meningitis. Recurrent can be in between, within 4 weeks maybe person can have many times, so that is recurrent. But chronic, when it persists for more than 4 weeks, we say chronic meningitis. So most of the time there is abnormal elevation of protein in the serum, and there is low glucose level or pleocytosis. Viral glucose level is many times it's normal. Pleocytosis, when we say the bacterial infection, most of the time it is neutrophilic type. When we see the parasitic, mostly it is eosinophilic. When we see the fungal, it is mostly lymphocytic, and tubercular also it's lymphocytic only. Signs and symptoms, maybe you will get either person will have fever, sometimes there is absence of fever but there will be like neurological abnormalities. So person can behave like they have remote memory loss or recent memory loss, or they can have the cranial nerve palsy. Sometimes they will be disoriented, confused personality, and sometimes they might have the papilloedema or some other ocular sign symptoms. So most common, the chronic meningitis when we see in India, the causative organism is like Mycobacterium tuberculosis. So that can cause chronic meningitis. Then bacterial other comes like Treponema pallidum, neurosyphilis, that can be caused by this Treponema pallidum if person is not treated or incomplete treatment, or if patient is like HIV positive, they may lead to this chronic meningitis by this syphilis. Listeria in extreme age group, they might cause like older age or younger age. Nocardia exactly doesn't cause meningitis, but it can cause brain abscess. This actinomycetes also that can cause meningitis. Brucella, it can cause chronic meningitis. Borrelia burgdorferi, initially it doesn't cause, but later on, late stage, it can cause meningitis. But we don't see in India burgdorferi. And like in Lyme's disease, this Borrelia burgdorferi that causes Lyme's disease. So initially, person will have erythema migrans. Later on, they can develop to CNS infection. When we come to the fungal infection, the most common positive agent, that is Cryptococcus neoformans, and this causes chronic meningitis mainly in HIV positive patient or other immunosuppressed patient. Like it can cause infection in hematological malignancy patient also. If patient has got transplant, then also they can get infection, or if patient is taking steroid for very long time, then also. Candida we see that is second most common cause, and Candida usually we see in like children, adult also we can see it can cause chronic meningitis, but mostly premature babies. Adult if they have shunt and all, then Aspergillus mainly it causes the pulmonary infection. Very rarely we get the CNS infection, but it does cause chronic meningitis. Histoplasma, blasto, this is also, these two are dimorphic fungi, you know. First it goes through the nose only, so primary it can cause the pulmonary infection. Later on, immunocompromised patient, they can cause chronic meningitis. Sporothrix, primarily it causes skin infection, skin and subcutaneous infection, in lymphatic drainage, it can cause infection, and later on, later stage, sometimes it can cause CNS infection. Coccidioides immitis, this one is not prevalent in India, but it is endemic in Western world. So if person they have gone sometimes, so there should be some travel history. So in Indian patient also you can get. When we see the protozoal or helminthic infection, acanthamoeba, that can cause the primary meningoencephalitis, and Toxoplasma gondii, usually in immunocompromised patient, that can lead to CNS infection. Tinea solium, as you know, that doesn't cause exactly chronic meningitis, but cysticercosis, you have to differentiate when patient comes. Angiostrongylus contonensis, basically this worm, this can cause like chronic meningitis like syndrome, because this will cause the larva migrans. So larva can go inside the brain. So as I have already told you that some of the fungal infection, some of the bacterial infection, that can, you should have a travel history. And neurosyphilis also, you should have the primary syphilis. Very late it can cause neurosyphilis, and mostly other fungal infection also you see in AIDS patient or other immunocompromised patient. Coming to the viral cause, HIV, as you know, that can cause chronic infection. CMV, also chronic meningitis, it can cause herpes simplex and zoster also, enterovirus sometimes. EBV can also cause the chronic infection. Just remember, in viral infection, sometimes protein is high in the serum sample, but sugar is normal. So for diagnostic evaluation of chronic meningitis, what are the things we can do? One is, like I said, that pleocytosis, there is like in bacterial or fungal, like acute cases you see the neutrophil count high, and chronic like tubercular you get the lymphocyte, fungal also you get the lymphocyte, sometimes eosinophil also, but mainly lymphocyte. Eosinophil you see in parasitic, and there is elevation of protein, decrease glucose level, so that will be there. Viral, I said that glucose level is most of the time it doesn't change. So other way of diagnosis, clinically okay, physician will see the sign symptoms, how they are behaving, and disease is more than 4 weeks. Radiological, we have some clue. It's not, uh, it's a provisional only, it's not confirmatory. Histopathologically, again, we can see the tissue reaction or some of the organism we can see. Microbiologically, direct demonstration, we might get something, or sometimes culture also helps, or serology like antibody detection or antigen might help, and molecular diagnosis in some cases. Direct demonstration, just I'll give some example, like if acid fast bacilli in CSF, the sensitivity of the direct demonstration like ZM staining is very low. That's why they do the auramine rhodamine stain, so that the fluorescent bacilli, even if in low number, you can see from the CSF. In India, in preparation, capsulated cryptococcus can be seen, and for candida, maybe you can do the gram stain, histoplasma giemsa stain. And parasites, some of the parasite like acanthamoeba, you can see the cyst in CSF wet mount, and Angiostrongylus contonensis, you can see the larva. If larva migrans, it goes to the brain then. And Like neurocysticercosis biopsy, maybe you can see the worm, and nocardia brain abscess, modified Jaden staining, you can see the acid fast bacilli. This is just example how you can get in like acanthamoeba, you can see the uh, cyst you can see in the tissue sample. Like wet mount, you may get like this cyst, folded appearance like this, and nucleus will be there. And Mycobacteria, I said in Jaden, there will be very few acid fast structure you can see. This is nocardia from brain masses, so you can see the branching filaments, acid fast. This is done by the modified acid fast. Cryptococcus in India ink or nigrosin stain, this is a negative staining. So you can see the budding is cells, background will be like black color or sometimes purplish color, and you can see either single or budding is cells. And histoplasma from bone marrow, not from CSF basically. CSF we don't have any cells. So bone marrow, just I wanted to show you the picture. So intracellular budding is cells you can see in monocyte. And in case of meningitis, usually we do the serology, antigen detection. And blastomyces, you may see like broad base budding cells in CSF sample. Blastomyces is reported in India also, it's there. So for culture, LJ medium, Bactec, Mijit, we can use for the Mycobacterium tuberculosis, because as you know that LJ medium, the sensitivity is very less. So Bactec, nowadays they use Mijit. So Mijit gives, that's a liquid culture, so that gives, it has got better sensitivity. And anaerobic culture like actinomycetes, you can grow actinomycetes. And for all the fungi, as you know that we use either brain heart infusion agar or saprot dextrose agar. So you can culture Cryptococcus, Candida, Histoplasma, Sporo, Aspergillus or Plasto. Coming to the serological diagnosis for neurosyphilis, VDRL is, it can be negative, but TPHA, that will be positive. FDA absorption test in the CSF, that will be also positive. So it has got, throughout TPHA is actually in neurosyphilis, it gives good result. It will be positive. It persists for very long time. Lyme's disease, we don't see in India, so you can detect antibody in CSF sample. Tuberculosis, I have already told you that either we do the direct demonstration by fluorescence staining, that is good. Second, we can culture in Mijit. Third, actually, PCR is very good for the diagnosis of tuberculosis. So diagnosis of parasitic disease, we have very less tests available. Either we see the like eosinophilia in peripheral blood, worms in CSF, or we can do antibody PCR for toxoplasma. So that way. Antibody histoplasma, we can do the antibody detection in serum sample or antigen detection in urine or CSF sample. Culture positivity is very less. And like histoplasma, just wanted to say that culture sensitivity is very bad, but this antigen detection in like chronic stages It's good. Progressive disseminated case also it's good. Acute case also it's good one. So we can do the antigen detection. Coccidioides and plastomyces, we can do the complement infiltration test. We can detect antibody in CSF and serum sample. Coming to the tubercular meningitis, one of the important this chronic meningitis cause. So it can affect all ages group, especially in children 5 years old is they are more prone, and if patient is not vaccinated, then also like BCG if a child has not taken, so they are on more risk, or malnutrition also, that is one of the factor child can get. Extreme old age also person can get, or if they are immunosuppressed, HIV malignancy also you can get, and diabetic also. So what happens when person gets infection in tuberculosis? So they will take from aerosol droplet, they'll take infection, then it will go to the lung, it will enter the alveolar space, they can form a granuloma, but when there is immunosuppression or anything, so they will just come out from this granuloma and they can enter nearby lymph node and multiple cervical lymph node, or other lymph node can involve, or mediastinal. Then from there again they'll enter to the by bloodstream, they can go to the brain, and brain it can cause meningitis. So they can involve the subarachnoid space, that can cause the meningitis. So that way person can get meningitis, and person will have low grade fever, they'll have malaise, headache, dizziness, vomiting, or altered sensorium. This you can get in any chronic meningitis, but low grade fever also. And problem with this tuberculosis is person can get the neurological sequelae. That is the problem if they are not treated properly. So again, as I have already told you, tubercular meningitis, you will collect the CSF sample. Zn stain sensitivity is not good, so we can do the oromin rhodamin stain culture. LJ is again sensitivity is less. So oromin rhodamin, how it looks, how it flourishes, and bactec or mizit, or mizit and bactec sensitivity is very good. PCR we can do, sensitivity and specificity is good. And this is just wanted to say that treatment in tubercular meningitis, normally short treatment can be given in other pulmonary, but here minimum is 9 months, maximum can go more. That's why I wanted to say that treatment is very long. When we come to the cryptococcal meningitis, so organism I said that is Cryptococcus neoformans or Cryptococcus gattai. There are two species of Cryptococcus, and mostly, as I have already told you, one group will be HIV AIDS patient, what we see in India, and nowadays collagenous disorder if they are taking steroid for a very long time, or hematological malignancy patient also we can get, or transplant patient. So Cryptococcus exactly like spores of the Cryptococcus person can inhale, and they can get from the pigeon dropping, eucalyptus tree, then they can inhale it. then it will go to the lung, then they can stay like subclinical infection like tuberculosis, they'll there. But when again person will have like they are immunosuppressed, then it can disseminate it to the different organs, so it can go to the brain. And when you culture from the CSF or CSF sample, you can get this black colony. And when we see the radiological picture, so you can get the ring enhancement like this. We can get and in parenchyma also you can see some enhancement. And what are the virulence factor that helps for the uh, this cryptococcus to enter the brain? So normally environmental cryptococcus, in environment also some cryptococcus are there. So why can't they cause disease? Because they cannot survive. Sorry, hello. So they cannot survive in the human body. That's why it cannot cause disease, because usually in environment in 25 degree they can survive. So growth at 37 is also one of the virulence factor to develop the disease. Second is, as you have seen in the Indian preparation, it has got capsule. So they will evade the immune system. So it cannot be phagocyte. So that can enter the pulmonary system and that can go to the different part of the body. And another is like phenol oxidase production. So phenol oxidase production, basically when you grow, so this is the melanin production, that is the phenol oxidase enzyme there in the fungi. So this one also helps for the entering the fungi to the brain, and that is resistant to this one is resistant to the some of the antifungal also. And urease production, again urease enzyme is there in the fungi, so that can be like again that will form alkaline in the body, and that can be useful for the organism to enter the brain. And coming to the laboratory diagnosis, again I have said that we can do the direct demonstration of the cryptococcus by India or culture we can do from the CSF sample, sometimes brain tissue, or for this from the sputum sample also. Or we can detect the antigen from serum sample, CSF sample and urine sample. So conventional method, as I have told you, that either you do the India, so you will see like this, or gram stain you can get, it's a budding cells, it's round stuff will be there, very big cell, but you can get confused. So India is the best. Negative staining. Culture important, because culture is different from the bacteria or other yeast, because it's mucoid, because since it has got capsule, so mucoid. And one biochemical like urease is very rapid in the sense when you inoculate within maybe in a hour you can see the urease production. So that way it gives rapid urea positive in the culture. And you can differentiate, this is the medium glycine and canavanine medium. So this medium CGB, bromothiamyl blue, actually CGP is not correct, CGB. So variety differentiate, you can differentiate like this Cryptococcus neoformans and Gattai. So usually Gattai here, the actually we have not added the bromothiamyl blue. This is the neutral red only. So color is pink color. So Gattai will give because that will utilize the cyanabinine, and neoformans will not give. And the serological test, we can detect antigen from serum sample or CSF sample. One is latex agglutination test, but you have to boil the CSF sample or serum sample. But nowadays, or you can use the ELISA also, but nowadays we have the rapid method, that is lateral flow assay. So we can use that one, and this one you can use in the bedside also. You don't have to process the sample. And treatment of Cryptococcus, just wanted to say that any fungal treatment is very long. So initially both amphotericin and flucytosine is given 2 weeks. Then they microbiologically they check whether that fungus is growing on the knot. If fungus is it doesn't grow on culture media, that means your patient is responding. Then you can give 8 weeks fluconazole 400 to 800 milligram per day. Then maintenance, that means if HIV patient, then maintenance is given for very long in HIV positive patient. So this is about the Cryptococcus and all the chronic meningitis, tuberculosis and Cryptococcus mainly. You can ask any questions.